Good. Okay. Well, welcome to Neurocare Academy. We have Ute Strehl here with us, who was assistant professor at the University of Tübingen. Ute was very well known for a lot of her research with SCP Neurofeedback, or slow cortical potential neurofeedback. So welcome, Ute, and thanks for joining us.
Thank you. Thank you for your invitation. Nice to be in Australia again. So I think I'm happy because not so many people are allowed now to visit your country, right?
Yeah, exactly right. Yeah. Well, look, it's fantastic to have you here. I'm very honored to speak to you. I'm sure you've got a lot of nice, interesting stories to tell us from your research history and the clinical application of that. So I would like to know a little bit about where you were born, your university education, and a little bit about just you yourself, how you grew up, and any anecdotes or stories that you've got regarding your early education and work life.
Okay, thank you. Okay. So you can see the map of Germany, and I was born in a little town near Göttingen, about here. Actually, my parents, both of them, were refugees from after the Second World War, and I think this is just quite an aspect that is very very hot right now, where we have so many refugees all over the world. And so they met there, and all in a sudden they got me. And then they went to Hanover, where I spent all my time until I finished school. And then I started to study psychology, the very first 3 years in Braunschweig, which is on the way to Berlin. And then I stayed in Berlin a rather long time, really the longest time of my life. I finished my studies there. And I started my professional life. And then in 1993, as you can see, the Berlin Wall was torn down. And shortly after this, we went from western part of Germany, of Berlin, to Tübingen. Tübingen is a very small town, rather small compared to Berlin, in the southern part of Germany. And the University of Tübingen and the sites of Tübingen are rather famous. The university was founded in 1477, so it's one of the oldest German universities, and it has a famous history of innovative thoughts, particularly in theology, in which the Tübinger Stift are famous to this day. So Philipp Melanchthon, the prime mover of building the German school system and a chief figure in Protestant Reformation, helped to establish its direction. And among Tübingen's eminent students and or professors have been the astronomer Johannes Kepler, the poet Hölderlin, the philosopher Hegel, and you may know this guy, the Pope Benedict XVI, as Cardinal Ratzinger was a lecturer at the university. And last but not least, this is Christiane Nüsslein-Volhard, the first female Nobel Prize winner in medicine in Germany. And she also works in Tübingen. And what you can see here is the first assembly hall of the university. And this is the assembly hall today. Still looks rather old, but it's still there, and it's a nice place, especially for those who are studying the law and, of course, for the assemblies of the larger parts of the university. And starting with the late 1990s at Tübingen University, the foundation work of mRNA-based substances, for instance, for cancer treatment and vaccines, which led through the PhD work and later research of Ingvar Hör, eventually led to the COVID-19 vaccine research programs that now are used by Moderna, BioNTech, and CureVac. But to say the CureVac, which was developed in Tübingen, is not as successful as are the other vaccines. So far, this is Tübingen, and yeah, probably you want to know more about it, or have another question?
Good. No, that's fantastic. Excellent. And so, so that's a really historic area that you did all your studies in, and it must have been a real honor to be part of that, such an amazing area.
Yeah. Especially now, when I looked back and when I produced these slides, I thought this must be interesting. And it's not, of course, it's no longer a university of theologists, but it has a famous neuroscientist branch now, and most of the research money that comes in is for the neuroscientists.
I see. It's interesting. All of that led up to what's being used at the moment with all the COVID vaccines, etc. Wow, quite an amazing place, and what an amazing era that you were part of. So that's fantastic. So then, after your studies, you got into doing some research with slow cortical potential neurofeedback, and you had some influence. Were you influenced by Niels Birbaumer at all?
Yes, of course. Actually, when I left Berlin, in Berlin, I was the head of a large student counseling center, and I had the idea that psychology did not do much for modern branches, and so then I had the chance to go to Tübingen, and I was really happy to see. Just a moment. To see that there's another way to. So he was the supervisor of my PhD, and he is a person who already in the late 70s started this biofeedback, and especially his very first publications are about theta feedback. And then he moved to slow cortical potentials with very famous papers. And he already had done one study with patients with intractable epilepsies, and he wanted me to do the replication. So I had to learn everything about EEG because I didn't know a lot about this. And I started the project, and finally this ended in my PhD. And this is unfortunately only in German. This is a publication. It was a small book, and it's called Epilepsy and Behavior, Development and Evaluation of Psychophysiological Treatment to Self-Control Epileptic Seizures. But don't worry, you don't have to learn German in order to read it. There are a few publications. One of it is this one by my colleague Boris Kochebe and me. And we, in this study, we compared SCP feedback with respiratory feedback and optimating medication in pharmacoresistant patients. So these were patients who had who did not reduce their medication, although they were medicated at the best level you can imagine. And while the participants in the respiratory feedback and the medication group did not reduce their seizure frequency, those in our SCP group, they did. This is what you can see in this little diagram. We had 33 patients in the SCP group. 10 did not change at all, so they didn't get better, but they didn't get worse. and 23 improve. And this is the distribution, how much they improved. And in these 3 patients, there were, with an improvement of more than 80%, actually there were 2 patients with nearly no seizures anymore. And another result of this study was that after slow cortical potentials feedback, the patients improved their IQ more than half a standard deviation, and this did not happen in the other 2 groups. And all participants reported better psychosocial and adjustment and improved their emotional state, but this was not related to seizure reduction, so we said this is an effect of unspecific variables.
So that, Ute, was a really landmark study in 2001, particularly with epilepsy, because neurofeedback, really the clinical application of neurofeedback with Barry Sterman began in the 1970s, and they were looking at SMR neurofeedback, and now we have the thought process that it's not only SMR neurofeedback that can influence behavior, but we have other things as well, such as SCP neurofeedback. And so did you start to understand the underlying mechanisms of SCP neurofeedback a little bit from that point?
It's difficult. We were always questioning ourselves, but especially Barry Sterman and Niels, why they decided to go in these 2 different directions. And they really didn't give an answer. I think, I don't know how this happened, but later on they concluded that probably in both feedback protocols, very similar mechanisms are involved, and they improve the feedback loops between the cortex and the thalamus. And by improving these feedback loops, patients will be able to inhibit seizures while they adjust the seizures just in the moment when they arise. You probably, from neuropsychology, you might know this so-called 2-stimulus paradigm. And this is when you give a so-called stimuli, maybe a beep, to your subject or your participant, and the participant knows after 6 seconds there will another stimuli arise, a beep or a bop. And whenever the second stimuli, which is called task here, is the same as the first one, the patient is asked to press a button as quick as possible. And in awaiting this second stimulus, the patient or the brain of the patient develops this huge, what we call electrical negativation. And this is a slow cortical potentials, and it has to be, it's different from the normal activity of the frequency bands. So you cannot compare this with alpha, theta, beta, or whatsoever. And these slow cortical potentials, they tune the cortical excitability. And they may shift either to a negative or positive potential. And this depends on the situation and internal requirements. And if you measure slow cortical potentials, you measure a moment-by-moment assessment of the unstable and fluctuating relation between excitation and inhibition. And if you look at this little piece here, this is the EEG of a 22-year-old man who gets a seizure because he is respirating too much. And normally in the EEG, you just would see this. Of course, you would see something is wrong here, but and you would know that this is a seizure. But if you use a different time constant, very, very, very low frequency band, then you will see this negative potential shift. And this is what we are interested in when we do slow cortical potentials training. So an epileptic patient should learn to reduce this negativation in order to avoid a seizure. And so what has this to do with normal behavior? Negativation, as I said, corresponds with reduction of excitation threshold. So you are more able to excite. You can mobilize your behavior or your cognitive resources. And this has been shown in many, many little experiments that reaction time gets shorter, signal detection is better, short-term memory is better, attention is better. And not to forget, so this guy should have hopefully huge negativation in waiting for the bang to start his 100-meter race. And while he is running, a negativation would not be so helpful. In this time, we would expect a positivation when thresholds are set high and he consumes the energy during mastering his task. If he would always think, oh, I am quick enough, and what is my, what are the other boys doing, and are the people, the spectators, are they applauding, and is my outfit the right one? If he would think about all these things, then he would have a negativation probably, and he would not be as good as possible. If you are interested in soccer, in Germany on Sunday, one of our most famous soccer player died, Gerd Müller, who did so many goals, you can't really count them. And he said, when you start thinking, it's too late. And this is, I think this is what he meant, what positivation is. You don't have to think, you just go. Whenever I showed this this schedule, very often therapists said, oh no, this is too much. This is too intensive, this is too ambitious, we can't do this. Actually, this is the protocol we used and we thought was quite successful. So what did we have? We had at least two phases with 10 sessions within 10 days. And during a session, we have different runs. And after one run, there is a break, and then the other comes, and then the other, and so on. And during one run, we have had 40 trials with feedback, half of them with negativity tasks, and the other half with positivity tasks. And in the end, from 1-3, you can start with, now we started just from the beginning, we include so-called transfer trials. And during transfer, the patient doesn't get feedback. So he seems to be a little bit blind. And this is in order to learn how to self-regulate without getting feedback, what happens in the normal world. And in the fourth one, it's the same. And after these 10 sessions, there's a break, 4 to 6 weeks, with so-called homework. During this time, the patient is asked to train as if he was sitting in front of the computer and try to self-regulate either negativation in the negative or in the electrical positive direction. And after these, after this first phase comes another one, again a break, and then another one. So this really seems to be a lot, but as we know now, this is nearly all you need, because you don't need booster sessions. Sometimes the patient asks for booster sessions because they feel unsecure whether they are still able to self-regulate. Then they can have one, but normally it's not necessary. And in the end, we have after 30 sessions everything is done. And if you compare, for instance, with behavior therapy, there 40 or 30 sessions is not much. If you don't do this in this intense way, you will have to use more sessions. This is our experience. And therefore, if possible, and this is what I tell the patients too, if possible, please let us let us train and do the treatment in this rather short run. And after half a year, you can go home and hopefully everything is fixed.
Fantastic. So you use this this treatment, I guess, procedure in quite a few of your research projects, your clinical research. Yes. Then after that, have you got some clinical research, the major studies that you'd like to share with us? Maybe your top 3 research studies that that you could explain to us.
Okay, so now we come back. This is epilepsy again. What we wanted to know is whether the effects we get are enduring, sustained. So this is what you have already seen, the seizure reduction. And then we asked the patients again about 8 to 9 years after, what's about your seizures? And if you look at these slides, this is the baseline before we started with the treatment. This is what we got after follow-up 1 year. And this is what the patient said, how many seizures they had when we contacted them again. And then we gave them the same questionnaire they had used already before they started the treatment. And here, so this is what we call new baseline. And as you can see, they are not seizure-free, but the seizures are reduced, and they have the possibility to stop seizures whenever possible. And this is, I think this is a result you never would get with medication, and especially not in these patients with intractable epilepsy.
Fantastic.
And to be honest, we didn't expect this result too. So we thought, okay, they were quite good during the training and 1 year at follow-up, but we didn't expect that they still were able to use this self-regulation and to have less seizures than before.
It must have been very exciting for you and your team.
Yeah, of course, yeah. Yeah.
Wonderful.
And the funny thing, when we were talking to the patients, there was one patient who said, I enjoyed the time with you, but to be honest, I don't use this self-regulation anymore. And then he explained how he is doing his work. He had to travel a lot, and in former days before he started treatment, he had the habit when the seizure came to look at his watch in order to see how long the seizure took. And we had during his treatment, we had. I had suggested, whenever you look at your watch, try to produce a positivation. And so when he was talking about his traveling now, he said, well, and you know, when I'm waiting for the train, I look at the watch, and then suddenly he stopped and he said, I didn't know, but I'm still doing the positivation. So this was a classical conditioning that worked even without consciousness.
Oh, fantastic! So that's great. So really, there's a direct clinical application for the SCP neurofeedback in epilepsy, but there also has been in ADHD, of course, hasn't there? Yeah. Would you like to tell us a little bit about your studies there?
Yeah, this is the application in ADHD, and this is a result of our first study where we used SCP feedback for half of the children, and the other half got a Theta feedback. We wanted to compare both And in the end, we didn't find much difference between these two protocols. For what reason soever, we don't know. And this is what we got about self-regulation in activation tasks, which is negativation tasks. These are the blue lines. And in the deactivation task, which is positivity task, this is the yellow or brown line. And first of all, what you can see from these slides, that the patients were fantastic, able to self-regulate. So when they should negativate, they were able. So here's the baseline. They were able to negativate. And when they should positivate, they were able to do this deactivation. And most important, in compared feedback and transfer, and that's what you can see during transfer sessions where they didn't get feedback, they were just as good as during feedback sessions. And the same is for the deactivation tasks. They were even better in the situation without feedback. So, and we took a closer look at these deactivation tasks, transfer tasks, and we found that treatment success was predicted by the ability to produce negative slow cortical potentials. And this is why we always say without transfer sessions, the training wouldn't be senseless. You have to introduce transfer sessions and you have to do it as early as possible.
Fantastic. And then,
okay.
Then you talked about follow-up there in that study, but you actually looked particularly at the sustained effects of neurofeedback after that point.
Yeah.
And really some of your studies are some of the studies that have the longest duration of measured sustained effects. So a typical duration is 6 months or perhaps a year, but you even have 2-year follow-up data.
Yeah. Yeah, this is because we really wanted to know it. 6 months after, people often say this is just placebo, and placebo doesn't work longer than 6 months. Therefore, we decided to have a longer period, and so these this is the follow-up, I think, was 1 year, and the rather very, very long period we had in epilepsy is just due to the many doctoral students who wanted to work with us. You know, I had to teach medical students in psychology, and we didn't just only talk about be friendly to your patients and try to listen to them, but we teach them in self-regulation and in neuropsychology and all this stuff. And then they always were very interested, and they came and said, oh, can I do my medical doctor with you? And then we rather often had to think about topics. And so at this point we decided, okay, then they can contact the patients that left us many years ago and try to see what they get. And so we had these nice studies.
Yeah.
So one more, this is the sustainability, or this was a 2 years follow-up. And this is interesting again. This is the ADHD group. And you can see we looked at symptoms of hyperactivity, of inattention, of hyperactivity, and of inattention. These got theta beta feedback, and they were the slow cortical potentials feedback. And all of them as a group, not every person, but as a group, at the 2 years follow-up were below the cutoff. So you could say they didn't have the condition anymore. And what you else can see, if you come from theta beta feedback, that they were symptom-free earlier than the slow cortical potentials group. So they were below cutoff only at 2 years follow-up, which is nice, because even if there's still a bit of symptoms after the end of training, you can expect that things will get better. And here is the same. But why were they better 2 years before? So we looked in our data, and we found that those who took part in this follow-up evaluation were the theta beta children who already had been successful at the end of treatment. Those who were not successful, who did not reduce their symptoms, they didn't show up. So this is just this is a funny bias, and we were happy to explain this. Now we need an explanation, why did they come and why did they not come, but I have no good idea. I do hope that we were not friendlier to them compared to them, but we don't know.
I see. Yeah, and so you do these controlled trials, and then I guess the next step from there is obviously the multi-center trials. So you want to make sure that these techniques aren't simply the result of a really good clinician in a particular center. So you want to be able to test these techniques over multiple centers. Can you, and you did that, didn't you?
Yeah, this is the next slide, and we had this really huge randomized control multi-center study with 150 children in 5 different centers. And here we compared slow cortical potentials feedback with EMG feedback, which we called a semi-active condition. And as you can see from this slide, both groups improved. If you look, this is the parents group, and the neurofeedback group improved significantly better than the EMG feedback. If you look at teachers, the difference is not as big. Of course, you want to know, why is this so? And if you go into these studies and into the literature, you will see that teachers' assessments are not very valid. So take care if you use teachers' judgment, because they are not, they may be blind because they may not know what happened to the child, that the child was in a treatment, but the judgment they give, we do not trust in them a lot.
I see.
So, and also our conclusion, yeah.
I was just going to say, it's one of the difficulties with neurofeedback for teachers is that the progress is slow, and so they might not see the changes over time, whereas they're used to seeing fast changes with medication. And
the teachers change. So the teachers in Germany, the teachers change at least every second year, even probably more often. And maybe this is the reason what you said.
Yeah, great, thanks. So the conclusion from that study was that neurofeedback was significantly more effective than EMG neurofeedback from the parent ratings. And where did you go from there? That was in 2014. Did you do anything later than that, or was that?
We have quite a few data that are still evaluated, and there's 2 new studies came out in the last one, just will be published in a couple of weeks, and the other came out last year about learning and about especially about learning. And what can we say about this?
It's fantastic that you've maintained connection with all of the younger students and helped to mentor them through.
Yeah, I have to correct myself. I did not retire in the 19th. I retired in 2010 about this. So 90s was wrong. I'm not so old.
No problem. Well, thank you for correcting that. But even after you retired in 2014, we see a publication in 2017. You've made a publication. So fantastic to keep you involved in the field with all your experience. Would you like to talk to us a little bit now, Ute, about how you see neurofeedback progressing? You've obviously seen a real timeline of progression in neurofeedback over quite a few decades. So it's fantastic to have your experience. How do you see the field continuing over the next 10 years?
In the beginning, when I stopped doing research in such an active way and having a working group and so on, I was rather pessimistic because I thought there's nothing happening. Later means in the last couple of months, I had the impression that research is going on. Not just cortical potentials research, but research about neurofeedback. We have quite a lot of interesting publications. We have this paper where we kind of self-obligation, how to do research and what to report. And this made me a little bit more optimistic. But still, I think to do research is really affording. If you think about the treatment schedule, it takes a long time until you have 20, 30, or even 100 or even more students or participants treated in your program. And therefore, this is not, as Birbaumer always said, treatment and clinical studies are not interesting for people young in their career because it takes too long in order to have results and in order to publish. Probably things have changed a little bit more, and now after we have shown in our clinical studies that neurofeedback is working, people may turn to more basic questions. So therefore in research, probably things are going forward, improving. Clinical translation seems to be even more difficult. And I think it depends. It depends, of course, on future research results. And it depends on the education of future therapists, be it psychiatrists or be it clinical psychologists. What background do we want for our therapists? And I would like to have neurofeedback and biofeedback as a subject of university studies, which is not usual, at least in Germany. It depends on the education of patients. Patients have to be compliant with self-regulation. As soon as you have a pill that has the same potential as neurofeedback treatment, patients will prefer the pill, except they don't like to take medications at all. It depends on the medical guidelines. Do they suggest to use neurofeedback? It depends on who pays. What about the health system? Does it enumerate patients who have to pay for neurofeedback? And last but not least, it depends on the equipment that is that is available on the market. And this equipment has to be reliable. It has to be valid. Does it really measure EEG if it tells us there is an EEG and this is SCP or whatsoever? And of course, it has to be cost effective. I did a lot of courses for young men and women who wanted to become a psychotherapist and who were very interested in these low cortical potentials and the other kinds of neurofeedback. And then they always asked, how much is it? And when they heard that it's rather expensive, at least to get a good, reliable, valid, and cost-effective equipment, they said, sorry, I can't afford this. And even if I said, but you will be much more successful, yes, we know, but we can't afford. So this is, for me, this is a very important point. So let's go to the example, Germany. In Germany, at least, we have neurofeedback recommended in the medical guideline for ADHD, for treating ADHD. So the recommendation is it may be used in combination with other treatment aspects, be it medication, be it parents courses or whatsoever. But this is so in the medical guidelines, we have nearly no doctor, no medical doctor who is interested in offering neurofeedback himself. We are happy if we know about medical doctors who tell the patients, you may go to Mr. X or Clinic Y and she will be able to do neurofeedback. This would be the best for you. There are a few, but not many. And by now, the health system pays, if you are a behavioral therapist, and if you if you are acknowledged by the health system, then you will get, the patients will get the treatment for free, and the therapist will get the money. And if you are an occupational therapist, this is even a little bit easier because they can treat patients with neurofeedback, and it will be remunerated by the health system. So these were quite good news. So this is more my critics, but on the positive side, I think we have shown that neurofeedback is efficacious, that the effects are sustained, and this is most important, that we have no or only temporary side effects, and that it's less expensive compared to medication and at least as efficacious. But neurofeedback does not equal neurofeedback. We have many clinics out there who offer neurofeedback, and they don't do what we understand what neurofeedback is and how it should be applicated. So the proper application should be proper. I have quite a lot of doubts regarding QE guided applications, and I have quite a lot of doubts regarding multimodal treatment, because I don't think that a lot helps a lot. With a patient who asks for neurofeedback and in my opinion is apted for such a treatment, I would always ask him to concentrate on neurofeedback first, and later one may think about additional treatments, but I would not give everything from the very beginning. So this is my the way how I look into the future.
Good.
I have another slide, if you still are able to.
Yeah, please.
Yeah. Okay. At least two other slides. You asked for comparison with other treatments. So what we get is biofeedback, and with neurofeedback, of course, too. If you look at this left part of this slide, the patient who gets a contingent reinforcement of a physiological reaction through biofeedback, he will perceive success. This will improve his self-efficacy. This will change his coping strategies for his problems. So this will lead to a sustained reduction of symptoms and improvement of performance because of brain plasticity. So this is the unspecific part of biofeedback. But we have another part. This is on the right side of the slide. To learn how to regulate the physiological reaction and to be able to adequate control is the specific part. So we always have both, and we should not neglect the unspecific part, and we should not neglect the specific part. So if we talk about unspecific and specific parts of the mechanism of effect of neurofeedback, then we have to talk about learning. And we have one publication that is now in press, where we show that in a comparison between EMG feedback and SCP feedback and Niels feedback, if we compare these three, we get head-to-head success in SCP and in Niels. But when we differentiate between subjects that were able to learn self-regulation and those that were not, we can nicely see that slow cortical potentials feedback is better than the other conditions. So if you only look at learner, you will see that the effects are even better. And I think this is something we have to, not we, but something that has to be followed. What can we do in order to improve learning? It's quite nice to have an effect without learning, but we do all this because we want the patients to learn self-regulation. And if we want to have sustained effects and sustained success, then learning might be really the important point. We still do not know a lot about how to define learning and how to improve learning. But as behavior therapists, we should be able, in cooperation with the technical people, to find a protocol that impedes learning. And this would be really nice to see this coming.
I think you've made a lot of really important points there, Ute, and with neurofeedback, yes, there are a lot of unspecific effects as well. There's the relationship between the therapist and the patient. There's the EMG biofeedback. There are many unspecific effects, but that point that you make about having sustained effects and having the conditioning of the EEG taking place for long-term effects, I think is really important. That's where the EEG equipment and the reliability and validity of the EEG comes into play, doesn't it? So the conditioning aspect and the specific effects. So look, your experience in this field is amazing, and it's fantastic to have you a part of Neurocare Academy's education program. So that's excellent. Is there anything else you'd like to end with? Any further advice that you've got for young up and coming neurofeedback practitioners?
I think I said so many things. So what I really would like to stress, because I very often saw that this was not done, start as early as possible with transfer trials. Don't worry if the patients don't like it. Just go ahead, build a good relationship to your patient, and then don't what my medical students rather often did. Don't think that you can just let the patient go in front of the program and let him work, and you can learn for your next examination. You have to be with the patient. You can't do several things parallel. You wouldn't do this as be it medical or psychology therapist. You wouldn't do that. So be with the patient and be an expert in learning and in self-regulation for the patient.
Great advice. Thanks very much. Really the best expert we have in SCP neurofeedback, Ute, and it's come straight from you. Thank you very much for all your time today. And look, I hope we can keep in touch and continue to gain from your experience in the future. So thank you very much.
Yeah, thank you for your attention. Bye-bye.